Well, disorders that are members of the obsessive compulsive and related disorders, or sometimes called the obsessive compulsive spectrum, have certain things in common, which is why they're grouped together in DSM-5. They are all characterized by either obsessive thoughts, recurrent, intrusive, unwanted thoughts, and or repetitive behaviors. So OCD, body dysmorphic disorder, hoarding disorder, all involve some repetitive obsessive thoughts. And then trichotillomania, hair pulling disorder, and excoriation, skin picking disorder are really characterized just by the repetitive behaviors. Those behaviors are not triggered by any particular thought. But these disorders also share other similarities. They're genetically related. They have other similarities as well. So that's, they were grouped together in DSM-5 on the basis of many similarities. They are different disorders, though, and it is important to differentiate them because the treatments do differ for most of them. So, body dysmorphic disorder is characterized by repetitive thoughts, obsessions, preoccupations, but it's about appearance. It's about perceived flaws or defects in one's physical appearance. So thinking, I look ugly, I don't look right. Some even think they look monstrous. And the repetitive thoughts trigger repetitive behaviors that are different than an OCD, like excessive compulsive mirror checking or excessive grooming. And you asked specifically about trichotillomania, and that is recurrent hair pulling, but without a triggering thought. So people are pulling out their hair, but it's different than in BDD, body dysmorphic disorder. People can pull out their hair, but it's because they think the hair looks ugly. It's just an ugly hair, or it's in response to thinking they have too much facial or body hair that they're trying to get rid of, or thinking their eyebrows are asymmetrical. So it's actually very important to differentiate all of these disorders because the treatments have some important differences. Yet there's still more we have to learn about mechanisms. Body dysmorphic disorder and OCD both involve abnormalities in the corticostriatal circuit in the brain that may most likely reflects the obsessions. We see hyperactivity in that circuit. That's a little different from trichotillomania, for example. Another important similarity is they share some genes. We know from pretty big twin studies that all of these disorders in the obsessive compulsive spectrum are genetically related. But we also know that they all have their disorder-specific genes. So body dysmorphic disorder, for example, shares some genes with OCD and the other disorders in that group, but also has some disorder-specific genes, and that's true for trichotillomania as well. And in terms of etiology, they all have different environmental contributors, so contributing factors, risk factors. An important pathophysiologic mechanism in BDD is aberrations in visual processing, what people with BDD actually see. They see something different than people without BDD do. The parts of the brain that are specialized to see detail are in overdrive in BDD. They're working too hard, so that those parts of the brain. So their brains are trying too hard to see detail. And then they also have difficulty visually processing the big picture of what they're looking at, so-called holistic or visual processing. So details overtake what they see, and it's hard for their brains to recognize that tiny details in their appearance are just really tiny. It's hard for their brains to contextualize that. So details look very prominent to them. And so a little spot on their face or a little asymmetry, of their nose, for example, to them looks huge and horrible. Whereas to other people, it's not visible at all, or it's barely visible. And this may be why people with BDD are usually certain or mostly certain that they really look abnormal or ugly, because they're actually seeing themselves in an abnormal way. Well, the diagnosis of the obsessive compulsive spectrum disorders is usually fairly straightforward. The big problem is asking patients. These disorders are very under-recognized in clinical settings, and patients can often be very embarrassed and ashamed of I find certain OCD symptoms, such as the sexual thoughts or thoughts of harming others, which patients don't intend to do, by the way. They're very ego dystonic, unwanted thoughts. But those thoughts are sometimes hard for patients to spontaneously mention to clinicians. People with body dysmorphic disorder often don't mention their symptoms, their worries to clinicians because they're embarrassed, they're ashamed, they worry that clinicians will judge them or negatively or consider them to be vain, right? Because they're so worried about how they look. And BDD is not about vanity, right? It's about having intrusive thoughts and not seeing yourself correctly. And then trichotillomania can be associated with a lot of shame, and skin picking disorder also. So it's very important for clinicians to remember to screen patients for these disorders. And they're fairly straightforward in terms of diagnosis. With OCD, you always want to ask about, whether the patient has any recurrent intrusive unwanted thoughts, and whether those thoughts trigger repetitive compulsive behaviors. With BDD, you can ask a very simple question like, are you very, very worried about how you look? And you can normalize that by saying many people with BDD worry about how they look. Is that a problem for you? With both BDD and OCD, we use a cut point of about an hour or more a day in total having these thoughts. And with BDD, we also require clinically significant distress due to the thoughts or significant impairment in functioning due to the thoughts. With OCD, it's at least an hour a day or clinically significant distress or impairment in functioning. So the diagnoses are usually pretty straightforward. If someone is worried about asymmetry, that's a pretty common concern of people with BDD. My lips are a little asymmetrical, or my hair is not exactly even. That's BDD, that's not OCD. Trichotillomania, you simply ask, and especially if people have noticeable lesions on their skin, or if you notice some thin patches of hair, you definitely want to ask about that. And ask if they're pulling, or ask if they're picking their skin. And if it's hard to control, repetitive and hard to control, they almost certainly have trichotillomania or sleep disorder. But with both of those disorders, it's important to make sure that the hair pulling and the skin picking are not triggered by thoughts that the skin or the hair look bad, because that is body dysmorphic disorder. And that's a bigger treatment that's needed. You not only have to address the skin picking and the hair pulling, but you have to treat all the rest of the BDD, the other symptoms as well. Well, I think of it more in terms of what are the evidence-based treatments for these disorders. And so in my mind, the compulsivity, impulsivity spectrum doesn't particularly influence my thinking about how to treat these disorders, although I think trichotillomania and excoriation parentheses skin picking disorder are on the more impulsive end of the spectrum, but still considered compulsive disorders and members of the obsessive compulsive and related disorders chapter in DSM-5. So for both OCD and body dysmorphic disorder, our first line treatment is serotonin reuptake inhibitors. We usually start with an SSRI rather than the SRI clomipramine, although that works also. It just tends to not be as well tolerated, but often is. And importantly, we often need higher doses of SSRIs than for OCD and for body dysmorphic disorder than we do for many other disorders. So I find that both of these disorders are often undertreated when SSRIs are used. And so, for example, for fluoxetine Prozac, we sometimes need to go to 120 milligrams a day. For sertraline, we sometimes go as high as 400 milligrams a day. And these doses are are supported by the APA practice guideline for OCD and by a paper of international experts on BDD that was published a few years ago, in which these kinds of doses are supported. And not everyone needs these high doses, but on average, the necessary doses of SSRIs are pretty high. That's our first line treatment. And then for excoriation, parentheses, skin picking disorder and trichotillomania, we tend to use the glutamate modulators, memantine, Namenda, and N-acetylcysteine, which is available as a supplement. And with those meds, I go up to, with NAC, as high as 1,800 milligrams twice a day. We always start at a lower dose and gradually raise it because not everyone needs that. And with memantine, I'll go as high as 20 milligrams twice a day, so a total of 40 a day. And these meds are the N-acetylcysteine, the memantine, are usually very, very well tolerated. So hoarding disorder, it's harder to treat with medication. And patients virtually always need a cognitive behavioral therapy. And I should mention that the therapy differs somewhat for these different disorders also. So we do standard exposure and response prevention with OCD, sometimes add in a cognitive component. The cognitive behavioral therapy for BDD is more complex. We do exposures, but more slowly than in OCD. We do the ritual prevention, very important, but we always add in cognitive therapy to help people recognize the cognitive errors in their thinking. An example would be, I can't go to the party tonight as my skin looks so horrible, everyone will think I look like a freak. And there are a lot of cognitive errors in those statements, like mind reading, fortune telling, catastrophizing, all or nothing thinking, labeling. We help people learn these about these cognitive errors and cognitive strategies. We also do some perceptual retraining in BDD, which is not staring in the mirror. We want people to stop staring in the mirror with ritual prevention, but we try and enhance their ability to see the bigger picture of how they look. Because usually when they look in the mirror, we know from eye tracking studies that they usually just zoom in on what they hate, a spot on their face or the shape of their chin, which they may not like. And it's hard for them to see all of themselves. So it's a quick mirror exercise, about 5 minutes a day, where they learn to describe themselves from head to toe, not zeroing on the things they don't like, and using neutral, non-judgmental language. We may need to use habit reversal training, a behavioral strategy, if they're picking their skin or pulling their hair. And we always recommend habit reversal training for trichotillomania and skin picking disorder, a simple behavioral treatment that can work quite well. Yes, I mean, I think there's always an effort, an interest in neuromodulation and certain form of TMS is used and approved by the FDA for OCD, not for the other disorders. I think what's exciting about BDD is we have 2 recent studies suggesting that we may be able, the medication, the SRIs often at higher doses in the cognitive behavioral therapy can work really well for BDD, but not everyone improves. And we have 2 recent studies suggesting that we may be able to enhance that global holistic visual processing, the ability to see the big picture when you're looking at yourself. One study used ITBS, which is similar to TMS, and showing that neurostimulation over part of the brain that's responsible for seeing the big picture did enhance participants' ability to see the big picture. My colleagues and I have a paper in press right now showing that we were able to enhance holistic visual processing, that ability to see the big picture, by teaching participants a computerized facial recognition task, helping them see fuzzy faces better. Both of these studies were in small samples. They haven't been replicated. So, we need more studies on both of these approaches, but they're promising, very promising, suggesting that perhaps by using a computerized task or perhaps some form of neurostimulation, we may be able to improve BDD symptoms in the future.